Hello YouTube, this is Dr. Joel again. This is video 2 of 3 on the complete blood count. If you need to see video 1, that's easy. Just click on the link for video 1 and it will take you right over there. In this video, I'm going to be talking about the red blood cells, hemoglobin, hematocrit, and some of the calculated values that you're going to see on a CBC. Video 3 is going to kind of top it all off. I'm going to finish with platelets, a couple of examples of just putting it all together, a couple of quick pointers, and then into some knowledge challenge questions, and then wrap it up. All right, let's get started for video 2 of 3. All right, jumping straight into red blood cells. So, because of my psychic powers, I know what you're thinking already. You're thinking, hold on, Dr. Joel, these are not all red blood cells. That's true. Only the first measurement here is actually red blood cells. The rest of these things give me evidence to support pathologies with red blood cells. So, what's inside of the red blood cell? How big are the red blood cells? Are the red blood cells variable in their size? Things like that. Okay, so the first 3 things here are things that the lab can measure directly. The last 4 things the lab calculates based on the previous values. And I'll explain this as we go. But first, let's start off with the basics. Red blood cells. So red blood cells, as you can imagine, are very important cells. Also, the most abundant in our bloodstream. Look at the 4th column of the row that I have selected. We're talking about millions of cells per microliter. Previously, when I was talking about white blood cells, we were only working with numbers in the thousands per microliter. So red blood cells outnumber their white blood cell counterparts by 1,000 to 1. As you probably know, they are involved in the transportation of oxygen from the lungs to the rest of the body, and then they bring carbon dioxide back from the body to the lungs so that the process can be repeated. They are fairly simple cells, and if you talk about them in their most basic terms, they're basically just a sac filled with hemoglobin, a pretty simple membrane and filled with millions and millions of these tiny proteins that allow for the transportation of oxygen. They do not have a nucleus. That's important because red blood cells cannot repair themselves because they have no machinery to do so and no instruction code, meaning DNA, to do so. Their shape is also important. They are what's called a biconcave disc. So they look kind of like a hamburger patty that's been squashed in the middle, and the outsides of the patty are still thick. This is good for increasing surface area, which we want so that we can exchange gases. But also it helps the cells to be limber so that they can get into tiny spaces, very small capillaries. All right? So now into interpreting some of the values. First of all, what do you think could cause an increased count of red blood cells, also called a polycythemia? Polycythemia vera. This is a disease wherein our bodies produce way too much red blood cells because of a problem in the regulation in the bone marrow. What else? How about high altitude? I live at a pretty high altitude, and so I see patients sometimes that are on the upper limit of normal for some of these values. It's just an adaptation that the body makes to compensate for the decrease in the partial pressure of oxygen. Related to that, let's say that you didn't live at high altitude, but your body still felt a low oxygen stress. That would cause an increase in red blood cell production, wouldn't it? What kind of diseases might do that? Well, there's a whole bunch of them. Congenital heart disease, wherein the heart is inefficient because of some anatomic problems. Or how about COPD, where the lungs themselves are unhealthy? That would definitely cause an increase in the production of red blood cells to try and compensate. Moving on, what about a decrease in the production of red blood cells? This is also called anemia. What do you think might do that? Well, again, a lot of things can do it, and I'm only picking a small handful here. But aplastic anemia is one thing. I've said this word a couple of times before. This isn't a pathology lecture, so I'm not going to talk about that very much. But basically, aplastic anemia is the decrease in production of multiple cell lines of blood. What else? How about chronic renal failure? Why would that do it? What do the kidneys have to do with blood production? I thought blood was made in the bone. That's true, but have you heard of the hormone erythropoietin? That's made in the kidneys, and it stimulates the bone, okay? What else? Well, what if you don't have enough nutrients to build the components of red blood cells? That's actually pretty common. Iron deficiency is a good one. I mean, that had actually better be at the top of your list. Pernicious anemia, which is a problem with vitamin B12. And pregnancy. Although that's not directly a cause of anemia, it kind of gives you a pseudo-anemia, just because a pregnant woman will increase the proportions of serum or fluid in the blood. It makes the cells just kind of look like they're decreased in proportion. Okay? Let's go on. The next item that we're going to talk about that is reported in a CBC is the hemoglobin. And the hemoglobin, the RBCs, and even the hematocrit, these three are closely tied together. If you see one go up, pretty much I can't think of any really good reason why one would go up without the other two. Although there will be some rare situations where that might happen. So real quick, what is hemoglobin? Well, hemoglobin is a protein complex that is involved in the transportation of oxygen throughout our body. You'll often see it abbreviated as HGB. Like I said earlier, red blood cells are basically just a sack filled with this stuff. So the dry weight of a red blood cell is going to be almost 100% hemoglobin. It's just packed with hemoglobin. Hemoglobin has a quaternary structure, meaning that there's 4 main protein units that come together to form the full structure. There are 2 alpha groups and 2 beta groups. Within each one of these monomers or groups, there is within it a heme molecule, which has an iron center, more specifically a ferrous center, which loves to bind oxygen. All right, so what might be a cause of an increase in this value on your CBC? Well, I'm going to cut to the chase. The increased values and the decreased values are going to be caused by almost the exact same reasons that we've already talked about when we were talking about red blood cells. And it's the same for hematocrit. Again, these 3 values are very closely linked together. If the body produces a lot of RBCs, well, it's going to fill them with something, and that's hemoglobin. So the hemoglobin is going to go up. And as I'll show you in a second what the hematocrit is, it'll make sense why that goes up as well. And vice versa if the RBCs go down. Okay? So let's get into it right now. Let's talk about hematocrit. So hematocrit is also called the packed cell volume. It is very commonly abbreviated as HCT. And as you can see, it's measured in percentage. So it is a volume percent or percentage of the red blood cells and everything in the red blood cells to the rest of the blood. And historically what they would do is they would take a test tube of blood that had a known volume or a known measurable height, and they would spin it in a centrifuge under very high G-force, and that would cause the heavier elements in the blood, like the red blood cells, to be forced to the bottom of the test tube. And then what you'd have is a very easy way to measure the percentage of red blood cells in the rest of the blood. You can see visually how that would make sense. Nowadays, we don't need to centrifuge the blood anymore. We can analyze it with computers. But the idea is the same, okay? So from this example here, you can see that about 45.2% of the blood volume is red blood cells. There is also a very thin layer of platelets and white blood cells in the middle. And then on the top, the top layer is serum. Okay? And I'm not going to go through which pathologies make this value increase or decrease because I've done it twice already. It's really the same as the previous two, the red blood cells and the hemoglobin. Next up on our list is the MCV, which stands for mean corpuscular volume, which is basically another way of just saying the average volume of the red blood cells. So how do you think you would figure out the average volume of the blood cells based on the three measurements that we've done above? Okay, so it's not too tricky. Basically, we take the hematocrit and divide it by the number of red blood cells in the blood. In other words, the volume of millions and millions and millions of red blood cells divided by millions and millions and millions of blood cells gives you the average volume of a blood cell. Cool? All right. So what do you think might cause the volume of the red blood cells to increase? This is also called macrocytosis. Well, first of all, anything that causes more reticulocytes is going to increase the average volume of red blood cells because reticulocytes are just bigger than mature red blood cells. So reticulocytosis is one. What else might cause that? How about folate or B12 deficiency? Also, some medications could do it, like maybe methotrexate or phenytoin. Okay, moving on to decreased red blood cell volume, also called microcytosis. Probably the two most common right off the bat, number one being iron deficiency, and number two, thalassemia. You can also see in anemia of chronic disease, hemolytic anemia, hereditary spherocytosis, and lead poisoning. All right. Now into the MCH, which stands for mean corpuscular hemoglobin. This is basically just saying the average mass or the average amount of hemoglobin in each red blood cell. So how do you think you would calculate that based on the values that we measured above? All right, it's not too tricky. Using the same logic that I just used, if we take the mass of the hemoglobin or the amount of the hemoglobin and we divide that by the number of red blood cells, well, we can figure what the average hemoglobin in each red blood cell would be. And it's really not very much. It's actually measured in picograms. All right, so what do you think are some things that would cause an increase or a decrease in the MCH? Starting first with those things that cause an increase. Alcoholism, folate deficiency, B12 deficiency. Sometimes these two, or the second and third one here, go along with alcoholism. Remember, people who are alcoholics often have poor diets. Liver disease, it could also possibly go with alcoholism. And hemochromatosis. What about decreased MCH? Sideroblastic anemia, which could go with what kind of poisoning? Lead poisoning. Good job. Iron deficiency anemia. Anemia of chronic disease is a good one. And thalassemia, which is pretty high yield on your test. You should understand thalassemias pretty well. Now into the MCHC, which stands for mean corpuscular hemoglobin concentration. In layman's terms, this is the concentration of hemoglobin in a given volume of red blood cells. Take just a second right now and see if you can think through how we would figure that out using the red values. Okay, so nobody's trying to trick you. It's as easy as the previous ones. Basically, we take values that we have. We divide the hemoglobin by the hematocrit to give us the mean corpuscular hemoglobin concentration. See how that makes sense? Okay, so what do we do with those values? What would you think of if you saw hyperchromic blood, or in other words, the MCHC was elevated? Well, truthfully, these things, both an increase and a decreased value of the MCHC, is going to be causes that are pretty similar to the MCH, right? I mean, that kind of makes sense. They're both kind of talking about very similar concepts, both kind of measuring the hemoglobin or the amount of hemoglobin. But even given that fact, I'm pulling a couple of new things here for this hyperchromic list. So that might be something like hereditary spherocytosis, hemolysis, sickle cell disease. This isn't exactly the same list as the previous ones, but some of the previous ones that I talked about in the MCH would cause the labs to be hyperchromic. What about hypochromic or decreased MCHC? Sideroblastic anemia, lead poisoning, iron deficiency anemia, anemia of chronic disease, and the thalassemias. So this list is exactly the same as the mean corpuscular hemoglobin or the lab value that I just talked about. Okay, again, those two are kind of related. Let's move on. Next up is the RDW, which stands for red cell distribution width. Now, there's two different ways in which this is reported. My lab reports the RDW-CV, but other labs might report the RDW-SD. They both do the same thing diagnostically, so I'm briefly going to talk about the difference, but that's not really what this lecture is for. So what does this mean? What does it mean to say red cell distribution width? Are we talking about how wide the red blood cells are, or how much volume the red blood cells have? No, not really, because we already know that value. Remember, we have the MCV, or the mean corpuscular volume. So we know the mean volume of red blood cells. RDW is more looking at the variation in the red blood cell size. You could have the mean at 92, which we know because we have it measured, and you could have a wide variation. You could have really small blood cells and really large blood cells. The mean would still be 92, but you'd have a huge variation. Conversely, you could have a perfect little row of 92 femtoliter red blood cells marching out. All right, so that's a variation in how much different the red blood cells could be. So let's look at this graphically. Okay, so here's 5 red blood cells, and they're all different sizes. The machine, or the counter, counts millions and millions of cells very, very quickly. And it doesn't take long to come up with a bell-shaped curve that shows a distribution of different sizes of red blood cells. So if we plot that and actually draw the bell curve, and then find the middle of it, what does that middle represent? Well, that's the MCV, okay? And we know what that is. That's 92 femtoliters. So what do we do with that? Well, we're interested in more than just the mean. We want to know the width of the curve, so to speak. So in the RDW-CV, which stands for coefficient of variation, we take a standard deviation of the curve and we divide it by the MCV and we get our value, and it comes out as a percentage. In the RDW-SD, which stands for standard deviation, we actually look at the width of the curve 20% up from 0. Okay, so it would look like this. 20% up, straight over, that width of the curve right there is your value. And it is reported in femtoliters, not percentage. So the two kind of do the same thing diagnostically. A big value says that your cells have a broad variation in size, and a small value tells you that your cells are relatively the same size. They both do the same thing. So again, we know the MCV, and we know a standard deviation, and so we can take those numbers, and we can calculate the RDW-CV. So what do we do with this value once we actually get it? Well, we use this value mostly looking at an increase in the deviation. It's really not possible for the body to make only 92 femtoliter red blood cells. There's going to be variation in all things, and there's a lower limit as to how small the variation can be. However, under certain circumstances, the width of that curve or the variation will increase, and that's the diagnostic importance of this lab. So, what are some things that could cause a large variation in the width of the curve, also called anisocytosis? All right, first on my list, vitamin B12 deficiency. What else? Folate deficiency, iron deficiency. How about hemolytic anemia? That makes sense, right? Also, red blood cell fragmentation. That also makes sense. If you're fragmenting or destroying your red blood cells, they are going to appear to be different sizes in the machine, right? And lastly, liver disease. But you can't take this value by itself. To make any clinically useful diagnosis from it, you need to use more than just the RDW. You need to incorporate other things like the MCV, okay? And I'll talk about that more in a future lecture. Again, this is just kind of an introduction as to what these values mean. Good? Awesome. Let's move on. Hey guys, this is Dr. Joel. That's the end of part 2 of the CBC lecture. If you need part 3 or if you need to go back to part 1, whatever you need, you can click on any of these links for those videos. Also, if you need me to make a video for something, send me some suggestions. I love hearing from you guys and I love your ideas. Lastly, give me a like, subscribe, and if you've got something to say, shoot me a comment. I do my best to respond to everybody. All right? Good luck in school.